Thank you. Thank you very much, sir. I would like to thank you, IS System, for inviting me for this talk, and I also like to thank you, Dr. Venkat, sir, for this brief and wonderful introduction. To start with the topic, I will, as everybody knows, is time is brain. If we delay in something, a diagnosis or delay in the initiation of the treatment, there will be definitely increase in the morbidity as well as the mortality of the patient. So we should act fast, and our doctors, especially our junior doctors, our resident as well as our nursing staff, contribute the large number of the medical fraternity. So we have to teach them so early identification of any deteriorating neurological patient. So if we teach them, if we make them aware regarding the any identification of neurological problem or early identification of any deterioration neurologically, then the further morbidity or the mortality related the patient can be tackled easily. Coming to any emergency, as we tackle, as we know that always we have to stabilize airway, breathing and circulation first. Then comes the complete physical history, the complete history and physical examination after initial stabilization. As this initial examination will establish its baseline data upon which we will compare the subsequent assessment and our judgment and our finding. Now, coming to the history part, as we know, the any neurology patient who is coming to neuro ICU or for particular emergency department, there could be a lot of, like, there could be complaints of headache, since like various types of headache. They sometimes make complaint of severe, the worst headache, they call as worst headache of life. Then we can expect to patient having subarachnoid hemorrhage. The patient may have present with a seizure, which can be new onset of the seizures. Patient can be present with any form of deficit, focal neurological deficit, where we can suspect any stroke or any bleed in the patients. Patient might be present symptomatically raised ICP like nausea and vomiting. Some patients may present with a recent history or recent history of trauma, any recent febrile illness, or we are going through a COVID pandemic. The COVID itself is a significant history where we will get a patient who is just recovered from the COVID, who is at home, but is suddenly started behaving abnormally. Then we'll evaluate and we'll find this having fungal sinusitis, or patient might develop a rhinocerebral mucormycosis. Thus, the history presenting events are important contributory to the examination. Now, coming to the previous medical histories, hypertensive patient, diabetes patient, or epilepsy, these are the important part where we can assess a neurological patient. Whereas how the hypertension is being controlled, a diabetes patient, they might be present stuporous, or they might be having decay component. Epilepsy, as already addressed, the patient might have previously trauma, or patient might be having any scar in the gliosis in the brain that may give rise to a scar epilepsy. Or patient might any having systemic malignancy, where we can assess the patient might have a cerebral metastasis, or patient might be having operated for pituitary, where we'll have some recurrence, or patient might have some hyponatremia, hypernatremia, electrolyte imbalance. As well as some patient may have already established a retroviral disease. There we can assume that patient might be having some HIV defining neurological lesions such as lymphomas, rare in opportunistic infections like toxoplasmosis, or patient might be having some cryptococcal meningitis. This type of will give a clue to the further further evaluation of the patient. Suppose patient might be having taking any anticoagulation, there we can suspect a patient might have any bleed, that will evaluate in that direction. So further, the compliance with the comorbidities, as you mentioned earlier, that is also important. Past surgical history is also important in that perspective. Of course, patient is having any VP shunt, or patient might be having undergone any endoscopic ventriculostomy. That may, suppose the shunt may not be functioning, or patient might be developing any obstructive hydrocephalus, or patient might have any developed meningitis, or this patient is under having sepsis with septic encephalopathy. These are further important points to remember when we will assessing a neurological patient if you obtain a proper history. Coming to the further evaluation, there are certain red flag signs we have to be addressed. Suppose patient of headache or recent onset, that may be showing of signs of raised ICP, like patient might be having vomiting or drowsiness, or any postural or progressive headache, that may alert to that taking nursing team or any concerned doctor should alert that the something wrong is happening, or there is something fresh event has happened, or the ICP is progressively going to rise, or new change in the focal neurological deficit, or the patient which is usually treated for ischemic stroke might have bleed or he is converted into hemorrhagic stroke. So any recent any new onset of the seizure, again we have to evaluate further, or any new or progressive neurological deficit, and also we have to look for any cranial nerve pulses like any visual disturbances, diplopia, sensory neural hearing deafness. So if you approach the patient, suppose we are having diabetic patient which is having giving fruity odor to them, he is already in encephalopathy, then we can suspect that patient might have a decay also, or patient might be inebriated, alcohol intoxication also. Suppose patient, you may encounter a trauma patient. Here in trauma patient, first you will see that there is a retroauricular ecchymosis or there is a racuni. There you should suspect the base of the skull might be fractured. So any nasal intervention like putting a nasal Rayleigh's tube or any nasopharyngeal airway or any nasotracheal intubation might be you have to be very careful, or you should be avoided unless until you have ruled out that base of skull fracture is not there. Similarly, if during initial history, if you are encounter the patient like this, some patients might be posturing, say there is usually we see decorticate posturing or decerebrate posturing. Both this posturing has inherent, they have very poor prognosis. So if the patient is like this, decorticate posturing, in decorticate posturing, what happens is the elbows are flexed, the arms towards going to the core, core, that is called as decorticate posturing, where the legs are internally rotated. Here in decorticate posturing, there might be having a significant cerebral hemisphere involvement. In decerebrate posturing, as you see, it is totally different. The arms are abducted and the arms are externally rotated, as well as the legs are also in the plantar flexion. There will take it, the patient might be having decerebrate rigidity. Both of these has a very poor prognosis compared to decorticate posturing. Decerebrate posturing has a worse prognosis. So if the patient is coming in like this, then we have to think of any like either patient might be have significant neurological damage, or patient might be having already has a significant damage in brainstem or cortical structures. Then briefly coming to the respiratory center, we have got like a control over the cortical area and pontine and medullary area, where certain centers are located which will coordinate the respiration along with our diaphragm and phrenic nerve. I'm not going into detail. So the point here is to make that certain type of breathing pattern which are common in neurological patient, especially when there is a involvement of significant brain trauma or involvement of brainstem, say ataxic breathing, where you will get irregular disorganized breathing with the depth is varying. There is suspect any medullary involvement, or some there is a Biot's respiration, where there is breathing is disorganized, irregular, with their in between periods of apnea. Here you will think of significant trauma, or you can think of any severe, or you can think of opioid overdose. Another breathing pattern which abnormally described here is chain stroke type of breathing pattern, where it is a crescendo decrescendo type of breathing, where their inspiratory is go on increasing depth followed by a period of apnea, then again inspiration with increasing depth. Usually this pattern is seen in where your brainstem is involved, or your any encephalopathy, uremia, or patient might be having congestive heart failure also. You may have a chain stroke type of breathing. Some part of like apneistic breathing, where you have both a prolonged inspiration as well as expiration. All this if there is a brainstem involvement, all these breathing patterns will indicate from the initial part that significant damage hasn't happened to the brainstem. Now coming to the Cushing's triad, this is important, where suppose the patient is there is a raised ICP, or will have a significantly increase in the blood pressure. There is a decrease in the pulse rate and respiratory rate. Neuro patient having, if we get these signs, then we can think of raised ICP. That's what it is like Cushing's triad. It is totally different from the Cushing syndrome, which is resulted from increased level of cortisol in the blood. Now coming to the altered mental status, there are, if you encounter a patient with altered mental status, you should have think of some potential causes apart from described before. like alcohol or any intoxication, electrolyte imbalance, hypernatremia, hypercalcemia, opioid intoxication, uremia, or patient having trauma, patient having hyperthermic, malignant hyperthermia, and like this infections, psychiatric disorders, stroke, seizures, and as well might be considered. Now, coming to assessment of level of consciousness, here we have usually use a three scoring system. One is called as AVPO score scale. Other is called as Glasgow Coma scale, which is very commonly used, which is given by the Graham Tisdale and John Brinett. The other score is called as 4 score, which is also known as full outline of unresponsive patient. Now coming to AVPU score. AVPU is a simple score where you will have to quickly assess the level of consciousness in busy emergency wards, where you have got, if the patient is alert, is responding to the your command, or is oriented and is responding its environmental stimulus, then we will say the patient is alert. If the patient is responding to the verbal stimulus, then we will say V. If the patient is responding to only painful stimulus, then we'll give it as a P. And U is like unresponsive patient. Coming to Glasgow Coma scale, which is very more commonly used, we have a three component, like I component, verbal response, and motor response. The minimal score is usually 3, and the maximum score is like 15. 15 is like a normal conscious patient. If you see eye opening is there, patient is spontaneously eye opening, then seeing here, and like we can say the E for response. On verbal command, if patient is eye opening, then we will give a 3 points. If the on painful stimulus, if it is eye opening, then we will label it as E2. If there was no eye opening to the even the painful stimulus, then we will give a point of E1. Then the verbal response, if patient is oriented, then we'll give a 5 points. If the patient is confused, then we'll give 4 points. Then inappropriate words, then we'll give a 3 points. Then if incomprehensible sounds, we'll give 2 points. If there are no sounds like V1, or some in intubated patients will write VT. Motor response, out of this three component, motor response has a maximum weightage. Again, a motor response is a 6 points. If the patient is obeying to the command, then we'll label it as a 6. If the localizing to the painful stimulus, we'll give 5 points. If there is a withdrawal to the painful stimulus, or the patient is having normal flexion, then we'll give 4 points. If the patient is having abnormal flexion, we'll give a 3 points. If there is a patient is having extension response, then we'll give a 2 point. If there is a patient is no response, then we'll give a 1 point. As already said, motor response is most important out of these three. Here sometimes we'll not able to, the most important part is deterioration of the GCS is more important rather than accurately noting it down. Say then again, Glasgow Coma scale, we can divide the TBI, traumatic brain injury, in 3 parts, like mild, moderate, severe. If the patient is having GSS of around 13, more than 13, then we can say it is a mild TBI. If the patient is having GSS of 9 to 12, then we can say moderate TBI. Any GSS less than 3, then it is a severe traumatic brain injury. More importantly, if the GSS is less than 3, that should indicate the patient for airway protection, or we have to intubate this patient. Coming to other score, which is also known as full outline of unresponsive patient. Here, what is there are 4 parts, like eye response, motor response. Instead of verbal response, we have got 2 brainstem reflexes and respiration. Again, this total score is like maximum score is 16, minimum score is 0. Again, here the 0 means like eyelids are closed even if painful stimuli, and 4 means maximum point. Here is eye open, or it is a tracking fully conscious patient and blinking to the commands. Motor response is again 0 is there is no response to pain, or there is generalized myoclonus, and 4 is like patient is showing thumb or peace sign. Again, brainstem reflexes, 0 means there will be no any pupillary, corneal, or cuff reflex, and 4 means all reflexes are preserved. Again, respiration, 4 is the patient having regular breathing pattern, and 0 means patient is not apnea, or patient is on breathing on ventilator rate. Now, coming to the pupillary examination, pupillary examination is forms one of the most important part of neurological examination. If you see pupillary reflex, Then we have got basically two nerves: optic nerve, which is the afferent, and oculomotor nerve, which is the third cranial nerve, which is the efferent. So if we show light to the right side pupil, you will get a constrictor response. To other eye also will get a constrictor response. This is the other eye which will not showing light, but it will get still constricted. It is called as consensual light reflex. It is a it will basically pupillary light reflex is also test your midbrain, where the nuclei of pupillary light reflex is located in the pretectal nucleus, and again it will rely on Edinger-Westphal nucleus. Coming to like different type of the pupillary abnormality. Suppose if we get like this meiotic pupil, patient might be having meiotic pupil where are not responding to the light. You can suspect a pontine lesion, or patient might be having opioid overdose, or sometimes patient might be having organophosphorus poisoning, or cholinomimetic drugs, or cholinesterase inhibitor like physostigmine intoxication. Coming to a dilated pupil, or otherwise dilated pupil will indicate usually poor prognosis. Bilateral dilated pupil might be seen in brainstem herniation, or there is a diffuse hypoxic encephalopathy, or patient has already received anticholinergic or adrenergic medication. Suppose there is a patient may having unilateral ptosis, then we can suspect a Horner syndrome, and that particular same site. In Horner syndrome, basically there is a damage of the cervical. There is a some lesion in the cervical sympathetic. We'll get a small pupil on the affected side. Patient might be having ptosis and hydrosis on the forehead, on the ipsilateral side. Here we'll see the Doll's eye reflex, or also known as oculocephalic reflex. It is a reflex will test your intactness of the brainstem. Here first we have to rule out the cervical cord injury, and where we'll rotate the head on the right to left direction. The pupil will usually go in opposite direction, as you'll see. That indicates that brainstem of the patient is intact. Usually, if severe TBI, if the patient is a hypoxic injury, or you are ruled out cervical spinal cord injury, or you are suspecting any brainstem lesion, this oculocephalic reflex is usually performed. If the reflex is absent, then we'll say Doll's eye is absent. If reflex is present, as in the video, then we'll present a Doll's eye is present in the scene in brainstem. Here the brainstem is preserved. Then other test is called as vestibulo-ocular test, where it is called as cold caloric test. We'll put a cold saline in one of the ears and irrigate. There will be having eye movements. So in this case, that also indicates that brainstem is intact. But you have to take care that before installation of any form of cold saline or warm saline, you have to see the tympanic membrane of the patient is intact or not. Coming to then unilateral pupillary dilatation, if you see there is in the raised ICP, or if there is uncal herniation where your third oculomotor nerve like is involved, then we'll get a dilatation of the pupil, because oculomotor nerve supplies the parasympathetic nerve fibers to the eyes, and which is responsible for the constriction of the pupil. Here the sympathetic fibers will over dominate and will dilate the eye. If you see unilateral dilatation, then always suspect some intracranial events or some uncal herniation if the patient is having some TBI or any previous stroke or any bleed. Like this, here we will see EDH, you can say uncal herniation. Now coming to third nerve palsy. If you see there is third nerve palsy in the right eye, you can see there is eyeball is gone down and outwards with a dilated pupil, because the third nerve usually supplies the most of the extraocular muscle, except our lateral rectus, which is supplied by abducent, and superior oblique, which is supplied by fourth cranial nerve. So in the absence, this eyeball is usually shifted down and out, and there is a ptosis. Here in the lower diagram, there is abducent nerve palsy, because the lateral rectus is supplied by the left eye, doesn't go in lateral direction as in the right eye. Here in left eye, there is a sixth nerve palsy. You can just evaluate roughly by this eye examination which cranial nerve can be involved. Now coming to facial nerve examination, say we have got like supranuclear or infranuclear, or upper motor nerve or a lower motor nerve. Usually Usually in upper motor neuron, there is always forehead is usually not involved, because it is forehead has a bilateral cortical presentation. So in if the only lower half of the face is involved, then we can suspect the contralateral upper motor neuron palsy in facial nerve. Or if the unilateral complete face is involved, then it is a usually it is a lower motor neuron facial palsy, which is called which is also known as Bell's palsy. You'll see here the right half of there is the right half of the face. There is this is ipsilateral right side lower motor neuron palsy. You can see the loss of nasolabial fold. There is loss of wrinkles on the forehead. Complete involvement of there is an infranuclear facial nerve palsy. Now coming to sensory system examination, we have got there is a dermatomal distribution of the human body. Say from the neck to the upper part of the chest, we are innervated with C3, C4, and C5. And upper part of the chest till inguinal region, inguinal ligament, we have got a thoracic dermatomal distribution. And lower half of the leg, we have got a lumbar dermatomal distribution. Similarly, on posterior side, similar distribution can be seen. Now coming to the motor examination, Medical Research Council has given a muscle power scale, which is ranges from 0, which has no contraction, to the 5, which is a normal power. If the patient has only flicker or flickering movement, you can say grade 1 muscle power. If the patient is having active movement but is not against the gravity, only sideways movement, you can say the power is of grade 2. In grade 3 power, the active moments are there, he can lift the extremity against the gravity. In grade 4, patient might lift against the gravity, but as well as in against the rotation, but definitely not a normal power. Grade 5 is labeled as a normal power. Then coming to the reflexes, upper extremity, we have got 3 reflexes: bicep reflex, triceps, and brachioradialis, where the nerve root value is C5, C6 for biceps, triceps is C6, C7, and brachioradialis reflex is usually C5 to C6. The nerve involved there for brachioreflex, where we will get a musculocutaneous nerve. For triceps and the brachioradialis, we will get a radial nerve. Now coming for the abdominal reflexes, the root value like around 8, 9, 10, 11, 12, or the nerve roots are involved. Knee reflex, ankle reflex, and plantar reflex. Like knee reflex, the root value will be L3, L4. Ankle reflex will be S1, S2, and plantar reflex will be L5, S1. For knee reflex, the nerve involved was femoral nerve, and for the ankle reflex, the nerve involved will be responsible for the tibial nerve. Now there is one concept called as upper motor neuron and lower motor neuron. In the upper motor neuron, which starts from the motor cortex, which the fiber through cortical spinal tract, they will descend to the anterior horn cell of the spinal cord. This track from motor cortex till anterior horn cell of the spinal cord will be known as upper motor neuron, and from anterior horn cells of the spinal cord through the axonal to the effector muscle, that is called as lower motor neuron. Similarly, if the bulbar involvement, corticobulbar tract, which starts from the your motor cortex till your medulla, there will call as upper motor neuron, and through the cranial nerve to the effector muscle, that is called as lower motor neuron. So clinically on evaluation, we can identify the lesion might be having a which is from upper motor neuron or lower motor neuron. See, in upper motor neuron, both like a tone is increased. Patient may present with the clonus, while in lower motor neuron, tone is decreased, and instead of clonus, there will be fasciculation or fibrillation, because in lower motor neuron there are still some muscle fibers, they might are still they are innervated with the nerve roots, so they fasciculate. Reflexes are usually increased in upper motor neuron, where they are decreased in lower motor neuron. The reason being, in the upper motor neuron, the upper motor neurons are damaged, the local reflex arc is preserved, so there will be increase in the reflexes. While in lower motor neuron, the lower reflex arc also damaged, so the reflexes, there will be there is flaccid paralysis, or there is hypotonia. Muscle mass is both in case muscle mass is reduced, but in upper motor neuron, if you get muscle mass, it is usually because of disuse atrophy. And in lower motor neuron, because it is a denervation which is responsible for the atrophy. In Babinski signs, say if you stroke the leg, will get definitely fanning of the great toes as well as a finger with a dorsiflexion is usually seen in this usually seen in upper motor neuron lesions. In lower motor neuron lesion, there will be mute plantars or there will be downgoing. That is seen in upper motor. That is seen in lower motor neuron. I got a video which will be seen in upper motor. Now this is called as Babinski signs is positive. Here you can see if you are stroking the leg of the patient, there will be fanning of, there will be dorsiflexion and fanning of the great toe as well as all the remaining toes. As well as this is a clonus. So if you put a power, then there will be rhythmic discharges. This is called as clonus, and there will be hyperreflexia.
Aggregated reflex, the knee reflex. When the knee reflex is checked, you can see the excreted responses there. And one more thing was present in this case was that the lead pipe rigidity was present.
Now coming for a cerebellar examination, cerebellar examination also important contribute to important part of neurological examination. Usually we test with the three things. Here we can have a finger nose test. Say if we ask the subject to touch our index finger and his nose, then he can do serially. That will this indicate that cerebellum is intact. Another test which can see the cerebral examination is dysdiacokinesia, that is rapid pronating and spinating movements of the hands. The other is the heel or to shin test, where the patient is sitting or in lying down position. Will ask the leg to from the right leg to will put a heel of the right leg or the shin of the left leg, and we have to slide down, and opposite can be done. That will tell the cerebellum is functioning. So this will cover the, I think this will cover the complete your basic neurological examination, from your sensory, your reflexes, from your pupillary examination, as well as your main Glasgow Coma and AVPU score. The most important point here to remember is that the accurate and consistent documentation we have helped to ensure the subtle changes in neurological status, and your neurological examination should be extensive, and you have to always compare your finding with your previous neurological examination. If any deterioration in the neurological examination, it should alert you to investigate further in the form of CT, MRI scan, and you have to take further decisions. Thank you.
Thank you, Durgesh, for that elaborative information. Any questions from any of our nursing colleagues? See, as a part of the critical care department and intensive care unit, Durgesh and me must have been spent maybe around last 15-20 years in ICUs. So what we request all our IDCCN students or other nurses who are interested in intensive care unit or working in intensive care unit or neuro ICU, we want you to do an inch extra than what a routine nurse should be doing. That is, other than you documenting about the drugs, giving drugs, caring a patient, you also should be examining the patient, also should be picking up the crucial important findings in intensive care patient, which will help our outcome and which will make the ICU a better ICU. In this regard, I will just try to re-emphasize few things which Dr. Durgesh is pointed out in his neurological examinations. In most of our patients, in your vital charts, you monitor the sensorium. Okay. I'm very sorry to say, many of the nurses may not put much intention when they actually write the GCS, or they may sometimes examine once in 4 hours or 3 hours and try to copy those the GCS. So I request all of you to understand the importance of monitoring the GCS and the change in GCS, which will help your doctor or your patient to make a better outcome. So all of you should be assessing your neurology. If at all a patient is conscious, awake, whose GCS was initially 15 by 15, but in the middle of your findings, if you find the patient to be drowsy and your GCS is dropping, I have seen many of our nursing colleagues who alerted me, sir, my patient looks drowsy. And most of the times, a simple glucometer test of glucose gives us a clue that this patient has a hypoglycemia. And we check the glucose levels which are low. And before a doctor reaches there, my nurse tries to treat these patients with 25% dextrose, bringing back the sensorium to normal. Okay. In many other situations, a patient who was admitted to the ICU for some other reason, and suddenly they found the patient to be drowsy. And when they examined, they found a patient is not moving in one of the sides, either a left side leg and upper limb, or sometimes it is right side leg and upper limb. In those situations, when we actually examined this patient and found to have a stroke, and when we do any investigations like MRI imaging or a CT imaging, we used to found a stroke or a CVA in this. Suppose you don't notice these things during your clinical examination, when your doctor, who generally may come once in 2-3 hours or during the rounds, these examination findings will remain unnoticed till your clinical examination is done by your doctor. So I want all the nurses to behave like a clinicians and do these examinations and give a clue to the doctor and make the patient's care better. There are many, I think, detailed things which Dr. Durgesh pointed out, not just the sensorium or one of the sides weakness, but he also spoke about different cranial nerve examination, different reflexes examination and all. See, so many times you may not be actively doing all this, but you will be observing these things when your medical colleague or a doctor colleague or a neurologist is doing. So you need to understand all these tests, including another important thing which I expect my nurse to do is pupillary reaction and pupillary asymmetry or asymmetry. You need to look at the size of the pupils. You need to look at whether it is a pinpoint pupil, dilated pupil, is there any difference in the two sides, and alert your clinician as early as possible. He also spoke about power. He also spoke about this different examination of the oculomotor nerves and other cranial nerves which are supplying to the orbit and also to the facial nerves. Many of the times these give you a clue. So just keeping your eye open in all these areas will make you a clinician rather than just a nursing area. So there are few participants who actually raised their hands. Neil, can we actually unmute them and allow them to ask questions?
Sure, sir. Sure, sir. So they can unmute themselves and ask. Celine.
See, there are 2-3 participants who raised their hands. Do they want to ask any question or any queries?
They can raise they can unmute themselves and speak.
Siloni D'Souza, do you have anything to comment? Okay. If there are no further comments, I just wanted to conclude the session by saying, see, you should be behaving like a critical care clinician and supporting the medical team, including the doctor team, to give a valuable inputs in neurological examination of a neuro patient. He may not be from a neurology ICU or a neuro ICU. He may be from a general ICU, where your neurological examination findings and giving those inputs to your doctor will make a difference of life. And I want all of you to do that extra bit of clinical examination, clinical finding, knowing the diagnosis, giving these inputs to the patient. At least I will expect that you should be knowing your GCS, knowing how to examine the power of the all limbs, and finding out if a patient is having any weakness in any of the sides. Then I will expect you to at least look at the pupils and alert your doctor if there is any abnormality in the pupillary reaction or the size. Other than that, any other examinations, add-on examination will be a bonus to you. At least these three things: GCS, weakness, and pupillary examination and high early alert to your doctor probably will help your patient to bring back early. Any final comment, Dr. Durgesh, on this?
Actually, yeah, yes, you already rightly said, sir, because early deterioration in the any GCS on of a patient is rather more important than documenting it hourly, because early detection of a drop in any GCS will alert the clinician, will alert the intensive or any doctor, so that they can act fast and they can take a decision for further any evaluation, like any MRI scan or CT scan, or patient might be shifted for a decompressive craniotomy if there is an increase in the size of the bleed or something. So otherwise that may go unnoticed for a few hours, and the few hours are very important, very crucial for the benefit of the patient, because it is a window period where we can intervene and we can improve the outcome of the patient. That is one part. And other part is like as you said rightly, like proper examination, including not only like neurological examination as well as other examination, like seeing a vital charts, early early identification of raised ICP in the form of like bradycardia or any sudden spikes in the blood pressure, or will target certain blood pressure target in stroke patient or in bleed patient, because sometimes the BP might be always changing. If you see, sometimes the BP is around those patients who are already thrombolized, if BP is shooting more than 200, this is the nursing staff will be there at the bedside. They might be looking only one or two patients. They can pinpoint on, they can alert the clinician, so that the clinician or intensivist may take action. So nursing education and nursing attendance and their the problem attendance is quite important. So they play a very important role. They will play a very crucial role.
True. I think another important point: any neuro-intensive care nurse who is working in neuro ICU, a patient who is having a bradycardia, who is having a hypertensive response. So this can be an early indication that your patient's intracranial pressures are rising. So you may need to alert your doctor or consultant other than the GCS, which may give an add-on clue. So these may also clues in patients who are sedated, paralyzed on ventilator also, because you may not able to assess GCS in them. And the only assessment neurologically you generally do is by looking at the pupils. So other than pupils, these kind of vital add-on charts like bradycardia, hypertensive response can also give you a clue of having a raised ICP. I think if we do not have any comment, we have some hand raised, but I don't know whether they are.
Excuse me, sir.
Yeah, go ahead, ma'am.
Sir, good evening. Myself, Brahmaramba from Lalita Super Specialities Hospital.
Yes.
First of all, it's a good presentation, sir. Very useful for our nurses, especially those who are working in neuro ICUs. We all of few candidates who joined in IDCC and we are attending regularly. It's been very useful for students, sir. Sir, my point is there any protocol to assess GCS and pupils? Like, I mean to ask, if you take vital signs, we used to check for once in every 2 hours. And if you take IO chart in ICUs, there will be a protocol to check once in 4 hours or 6 hours like that. So in a similar way, is there any protocol to check GCS and pupils?
Dr. Durgesh, you want to answer that question?
Yeah. Actually, as such, there is no laid protocol for the assessing how frequently you should assess the GCS or it is like you can assess like how frequently you can assess. Like sometimes we may see that the patient might be having like just thrombolized the patient, just came from the emergency, or we just thrombolyze the patient. Such patients, we might think that that patient may deteriorate very rapidly. Here we can assess the GCS like every 15 minutes. Like we are taking like our BP vitals. There also we can check the GCS like as well as people also every 15 minutes, because to know it at the earliest. As such, there is no laid protocol because it is a clinical examination. How frequently you can do it, that is up to you. But like usually we do it every acute patient just wheeled in the ICU with recent thrombolysis or recent like any injury and all. We usually go for hourly GCS as well as like pupillary monitoring. But it can be again more frequently can be done because the nurse is standing at the bedside. You can do more frequently, like twice or thrice in the hour.
Yeah. Yeah, I think that's fair enough. Brahmanamba, actually the answer is, if you look at our routine ICU charts, the GCS and other vitals are monitored hourly. Okay. But this varies with the clinical context, as Dr. Durgesh rightly pointed out. If you notice a patient to behave little abnormally and looking drowsy, in your presence, you may start monitoring this patient's GCS and other vitals more frequently, including pupils. But routinely in intensive care unit, in a neuro ICU, in a stable patient, we document it hourly. But once you notice a abnormality or a situation, as he rightly pointed out, a post-thrombolytic condition, a patient who just got intubated after a drop in GCS, these are the situations where you may do a more frequent GCS or more frequent pupillary examination. The time for this more frequently examination will depend on the seriousness. Maybe as frequently like every 10 minutes can be an option, every 15 minutes can be an option. It depends on your clinical context on that way. But otherwise, regularly we do it every hourly.